Hi, good evening, good afternoon, and good morning to some of you. On behalf of the Eastern Mediterranean NCD Alliance, I would like to extend a warm welcome to all of you. In today's session during the London Cancer Week. At the outset, I express gratitude to the organizer team of the London Cancer Week for this great opportunity. Over the years, our collaboration with London Global Cancer Week has been significant, driven by our shared goals in the fight against cancer and the improvement of cancer care in the region. Thank you all for joining us today. We mark the USC Day. Our focus today on cancer and universal health coverage. Why universal health coverage? In September this year, government worldwide, including our region, reaffirmed their commitment to ensuring that the right for healthcare, including cancer care for all their citizens, regardless of the location or any other difference. So there is a call for health for all. This promise, we want to discuss this promise. Is it a reality? And how far we are from this reality? In our region, despite this commitment, many countries still grapple with the access to cancer care. And when I talk about cancer care, I want to say cancer care, the whole continuum, from prevention, screening, early detection, treatment, as well as palliation. Roughly half of the population in our region lack access to essential healthcare services, including cancer care. And even certain country faces difficulty and challenge because of their humanitarian crisis, and you know that very well. I want to share with you a few examples of why we are very keen on raising the issue of equal and improving cancer care and including it in the universal health care package. So let me share with you some slides we have used or published recently in our publication, Cancer Control in the Eastern Mediterranean region. And I hope you can see this slide. You could see, how many, the country varies in terms of the box here, share out of pocket expenditure on healthcare, data from 2017. This is one of the publication we have done on access to cancer care. And you could see that country varies in the region in terms of individual share of the healthcare expenses. And it goes from 81% share, the 81% people share for their healthcare to like 6 or 7% in some GCC country. So there is a variability. However, also there is too much depending on individual to pay for their healthcare. Similarly, in that paper also we have facts regarding availability of essential part of cancer treatment, which is PET scan. And you could see, and I think our panelists will allude to that and give more detail. You could see the figures. There is also huge variation and disparity in the region, and also reflect a gap in this area. So based on this issue of gaps in services of cancer and our desire to improve the cancer care in the region, we have in this session today, we will discuss this issue with our esteemed expert from different area of cancer care. And also, we want to raise with them question regarding, can we turn the promise of accessibility of cancer care into reality? So everyone will be having equitable, quality cancer care. How close we are to achieve the universal coverage goals, by 2030. What are the challenges impede the attainment for universal health coverage for cancer care specifically? And lastly, how can we advocate with the government to integrate cancer care into universal health care package? Our agenda today, we have two parts. The first part, we have a 25-minute presentation providing deeper insight into the meaning of universal health coverage and how WHO strategy support country in reducing this disparity and financial hardship in cancer care. The second part will feature a moderated panel discussion with our experts and panelists representing various parts of cancer care continuum, and I will introduce them later based on the discussion. And we encourage you as our audience to participate actively, and we have allocated 15 minutes, in fact, for a question and answer at the end. So once again, I appreciate your time and your presence today. Without further ado, I would like to welcome Dr. Asmas Hamrich. He's the director of the NCD Mental Health and Universal Health Coverage Department at WHO, IMRO in Cairo in Egypt. Welcome, Dr. Asmas, and the floor is yours.
Assalamu alaikum. Good afternoon. Thank you so much, dear Dr. Ebtihal, dear colleagues, ladies and gentlemen. It's my great privilege and pleasure, of course, to be with you again in the London Global Cancer Week this year. I believe this is the fourth year in a row that we have been kindly invited with many of you, some old friends, some new colleagues joining us with a strong focus on our work here and our joint efforts in the 22 countries of the WHO Eastern Mediterranean region. I'm very happy to be here with my esteemed colleague, Dr. Lamia Mahmoud, who's our regional advisor for this particular area of work. And of course, many of us have already interacted, in the EMR countries or even elsewhere in the recent past. And of course, we really have a very interesting set of challenges, but also achievements in front of us in our region. So, Ibtihal, would it be possible to kindly start my presentation from your end? Let me just see if that's possible.
Yes, can you see the slide now or share? Oh, sorry, it's starting sharing.
Now I can, yeah. So we just have to go on slide presentation mode. Wonderful. Okay, great. And I'll let you know when to kindly move on. So I was asked to kindly present on cancer care in the area of universal health coverage, which is an interesting reminder, certainly for me, and I think for all of us, in terms of what we actually mean with universal health coverage, and perhaps even a little bit of a historical reflection. And since we have all grown up in slightly different places, we all have different memories also. I'll come to that in just a moment. What I have put up front here is actually the special edition report, the special report on cancer control. I have it here in my hands in front of me. I often refer to it, and many of you are co-authors of this report. I believe it's the most recent comprehensive update for the countries of our region, and it was a great pleasure to contribute, and I think it's a great reference. So I have put on the bottom of my slide, which of course will be shared with all of you after the presentation, the free link to the PDF of individual articles, but also the whole issue together, which I believe can be a great common denominator for us. Next slide, please. So I would like to talk a little bit about the regional cancer burden and trends in our region, about the concept of universal health coverage, about region-specific challenges as we perceive them and then the opportunities and the way forward. Next slide, please. In terms of the cancer burden, and we have the 22 very heterogeneous member states, of course, of our region here on the right in different shades of blue. So just a word on the region itself for those colleagues who are not acutely familiar. We basically have, the countries of the Arab world, but we also have Iran, Afghanistan, and Pakistan as part of our region, very importantly, especially Pakistan as a very populous country, of course, weighing heavily in our statistics. And I think when we look at the burden, both in terms of morbidity and mortality of cancer, it's very concerning in different ways. Number one, I believe we have the highest incidence rates in the world now in terms of the 6 regions of WHO, with almost 75,000 new cases and 460,000 deaths reported in 2020. And it's also now the cancers together is now the second most important cause of NCD-related death after cardiovascular diseases in our region. We have the common culprits for men: lung, prostate, liver, colorectal, and bladder in that order. For women, breast, colorectal, liver, thyroid, and ovary cancers in that order. So we have a lot of particularities, also variations across the region. You can see that from the different shades of blue of the different countries in our region. And we have a really alarming, of course, incident rate of new cases in our region. Next slide, please. When we look at overall trends, I should say demographic trends to start with, we all know that we have a very rapid population growth with population numbers between 2020 and 2040 almost doubling. You see that on the top right. And at the same time, of course, as almost everywhere in the world, I believe we have an aging population. And together, that means we have a lot of, a new cancer coming into the equation. And we do have, of course, a very challenging profile of high-risk factor prevalence related to cancer, starting very much with tobacco, but also with electronic nicotine delivery systems and even non-nicotine delivering systems in use now by populations in our countries. Overall, high overweight and obesity, overall physical inactivity, very important in many countries. Unfortunately, also unhealthy diets, especially in young people and people who often don't have, the means to afford, healthier diets. We also struggle with optimal breastfeeding, and in many places we suffer, all our people suffer, high air pollution, all contributing, of course, to cancer on top of the genetic burden, of course, that many of us carry. And what that means is that now every third cancer in adults in our region was due to modifiable risk factors. So a lot of work ahead of us. Those are figures from the IARC, the International Agency for Cancer Research, our sister agency in Lyon, France, 2020. Thank you. Next slide, please, Ibtihal. So moving on to universal health coverage. And I think if we would have sort of to answer, the question of what it actually is blindly, we all would have similar but slightly different definitions. I'm using a definition that, comes from our one of our last World Health reports in 2010, actually, on UHC and health systems that defines UHC as all people to have access to the full range of quality health services that they need when and where they need it without a financial hardship. And that is very much related, of course, to the global health goals and targets that we are all familiar with. The United Nations Sustainable Development Target 3.8 to achieve UHC with the two main elements, the risk protection and the healthcare including affordable access to quality and affordable essential medicines and vaccines for all, which is critical for cancer, of course. We had then, of course, a great global consensus also at the UN General Assembly special session in 2019 on UHC, where it was stated that health is a precondition for an outcome and indicator of the social, economic, and environmental dimensions of sustainable development. And then, of course, our WHO program of work 2018 to 25, and subsequently the new, in planning global program of work that we're currently discussing with all our member states, that is stipulating 1 billion more people benefiting from UHC by 2025. So in other words, universal health coverage as a concept in this definition is really a centerpiece of global health, and is playing a major part of our also regional and national advocacies. Of course, when we talk about it, we often mean the key elements, or and I'm listing some of the key elements on the right. The actual benefit package itself, including, of course, interventions for the prevention control of cancer, the finance part of it, the financial protection, but also the sustainable health systems financing, the qualified health workforce, the overall governance, and very much a focus to an inclusive, equitable primary healthcare approach. Next slide, please. Looking a little bit into, or a reflection on progress in terms of our efforts to move towards universal health coverage, this is pretty much, meticulously monitored now, but different metrics that we use within the United Nations, including WHO, including other UN agencies, including the World Bank, and the aggregation of those indicators in terms of moving towards universal health coverage doesn't look very promising at the moment. The world overall is off track. A couple of years ago in 2021, a little bit more than half of the global population were not fully covered by essential health services, including those ones for NCDs and cancer. About 2 billion people are still facing financial hardship. And for example, in our 22 countries in the Eastern Mediterranean region, a high out-of-pocket spending pushes more than 8.2 million people into poverty, and 2.6 million even into extreme poverty. That's taken from a publication from our own team here in EMRO recently. And of course, the COVID-19 pandemic further worsened the scenario by disrupting essential services, more than 90% in countries globally. And even a year later, 84% of countries globally reported disruptions related to the hardship and the challenges of COVID-19, including financial losses, of course, and brain drain and whatever it was. And at the same time, we do continue to have great inequities and inequalities in terms of out-of-pocket payment, especially certain population groups, socioeconomic strata, but also, migrant populations, other disadvantaged populations. I just want to direct your attention briefly to the right from, our sort of textbooks, so to speak, and WHO's World Health Reports of the past, where we try to define, again, the 3 dimensions of universal health coverage in terms of the percentage of population covered, in terms of the comprehensiveness of services offered and covered, but also the cost in terms of coverage or payment, or rather co-payment of populations. So it's very easy to fall through the cracks, I believe, in one of those dimensions. And we all know that sometimes we on paper have full coverage, but then we still have co-payments on the expensive services often related to cancer, of course, are not fully covered at least, and that is a great hardship for many of our people. Next, please. So I think the slides just now show that we face a particular challenge in cancer because of its complexity and also the services, the sophistication of services needed, and the costs attached. And if we look at overall challenges to cancer response in terms of achieving full coverage, we have grouped here into 3 different areas. The contextual challenges in terms of the great number of emergencies and political instabilities in our countries, and oftentimes related a workforce migration out of our regions, a region or sometimes from those countries in the region affected by emergencies to the wealthier, more stable countries, better paying, of course, countries. We have a particular lifestyle issue, as was mentioned earlier, for example, with physical inactivity and so forth. And we have a pretty high tobacco use and also now novel product use, especially in men at almost 20%, one of the highest in the world. We have, therefore, particular financing challenges in terms of relatively low coverage, high out-of-pocket spending, oftentimes limited public funding, or also how can I say public sector involvement, private sector involvement that is not necessarily beneficial for the poor, and also relatively high cost of cancer medicines and technology in many countries. And on the right, other systems challenges in terms of the highest level, attention and ability at political level, human resource capacity and diversification, access to particular services. I'm thinking of access to opiates, for example, which is critically difficult in many of our countries and many settings. Ironically, in a region that produces most of the world's opiates, of course. Then also sometimes a competition within the health system is a competition between other disease areas such as communicable diseases when it comes to funding, and also program planning in terms of skewed plans, not favoring needs-based planning and implementation for NCDs such as cancer. And in many settings, of course, we also struggle with insufficient or outdated data. When we look at cancer registries, of course, there's much potential to improve issues. So we have a whole gamut of challenges. But next slide, please. Let's look at the brighter side and the different opportunities that we have and the way forward. I think we all know we have a great set, and this is of course a little bit the WHO or United Nations perspective, but I believe having lived and worked here in Cairo for more than 8 years now, that we have a wonderful set of evidence-based so-called best buy interventions globally, which were also translated by our regional committees sessions here over the years, basically the last decade, into EMRO-specific actions and indicators. So we know exactly what to do. Not only have we those strategic interventions, we basically also have packages like Empower, like reduce fats, like alcohol reduction. For every risk factor, every disease area, including for cancer, we have best buy interventions and packages. And we do know that they're best, in a way, tackled cost effectively if we start at the community and primary healthcare level. We also have unprecedented opportunities in terms of digital health. And digital health is often understood as something high-tech, high-end in the health system. But I believe that digital health can particularly benefit rural populations, disadvantaged populations, for mobile phones, through mobile phone services, for example, better planning, better access to services, even primary healthcare clinics, for example. So there's great potential in digital health, and we're proving that around the world now. We also have great potential for public health partnerships, public-private partnerships, I mean, critically involving the non-for-profit arms of private sector, oftentimes to, for example, have low salt and fat and sugar diets made available. There's many other examples. You may mention them in your interventions kindly. And I think we have great new guidance and also, evidence and experience in terms of palliative care, including home-based care, linking to what I mentioned earlier, access to opiates, for example. Next slide, please. We also have, I think, great agreement in terms of what needs to be done. This is the regional committee, in other words, Ministry of Health, approved framework of action for cancer prevention and control in our region. Clear agreement on what needs to be done and how it needs to be measured in terms of cancer governance, prevention, early detection. Next slide, please. Management, palliative care, and surveillance and research. These documents they're all available in our repository on our website. I have the link on the last slide. And those of you who haven't seen them, please have a look, because they have greatly, of course, guided countries in national planning and monitoring for cancer prevention and control. And just a year ago, the regional committee in our region approved also specifically a regional cervical cancer elimination strategy, which is really taking off in many of our countries in the EMR now, based on the global elimination strategy of WHO that was approved by the World Health Assembly just the year before. So great opportunity to scale up here. Next slide, please. And another important publication is our Eastern Mediterranean Health Journal. That's our WHO EMRO in-house journal, special issue on palliative care. That's also just a year old, with excellent research articles from you, from the member states, reports and reviews. So we have a lot of new evidence, a lot of new initiatives, a lot of new guidance and experience from our countries. And that's really, I think, the good news and something to be proud of and something to build on. Final slide, please. So I thank you very much for your attention. This is the link to the full repository of all documents of WHO. And you see on the bottom two additional icons. The right one is the icon of, in a way, the global, UN General Assembly consensus on what should be focus of NCDs and mental health. And you have the important risk factors on the right, you have the diseases on the left, and you see very much that cancer is part of that, and the important risk factors that will guide us over the next 7 years, at least until the SDGs in 2030. And you have on the right the Sustainable Development Goal on health and well-being, number 3, with the target 3.4 on reducing by 1/3 premature mortality from NCDs. And I believe this is very much related to our topic here and our joint efforts in cancer. So I thank you very much for the opportunity, for listening to me, and I'm very much looking forward to the further interventions. Thank you so much.
Thank you so much, Dr. Asmas, for the great setting the scene and presentation. So, WHO General Director once said universal health coverage is one of the best and novel concept in public health, because with this is the lead for achieving Sustainable Development Goal. I will go ahead, move to Dr. Lamia Mahmoud she is the regional advisor for non-communicable disease prevention and in the regional office, WHO EMRO. And Dr. Lamia, we want to hear from you also about what's WHO strategies and policy in place to support country to achieve the universal health coverage within the area of cancer control. Thank you, Dr. Lamia.
Thank you, Dr. Abdihal, and very happy also to be part of this year's London Global Cancer Week and to be able to present. I will share my screen just so that I'm able, hopefully, to move more quickly in terms of delivering the presentation. Please let me know once you see my screen.
Yes, we can see your screen.
Yes, clear.
Surprisingly, I can't see it. I'll just hold on.
It might take a few seconds, and please, if you could put it on the show
I
mode.
can only see it very minutely, surprisingly. So, shall I stop sharing and let you share from your side, Ibtihal? It's.
I don't have a slide. If you want.
I sent it to you.
Maybe you can just press on the what you call it on the corner there with presentation.
Presentation mode. Yes.
Yeah.
Just present. It's unfortunately not giving me that. So
there's a view icon as well, Dr. Lamia, on the top right hand that can give you options.
Yeah, but it's not giving me that option. Ibtihal, I shared with you my slides.
Yes, please. Yeah, send it to me. Yeah.
I've shared them already. I sent them. So technology fails me, but
you are more than welcome, Dr. Lamia. And yes, yeah. All right, let me. Okay, it's there with Dr. Asma's presentation, right?
No, I just sent it just before the session started,
Mm-hmm.
as if expecting some hiccups. Are you able to find them? Let me give it another try.
Yes, just a minute, a second. Yes. Yeah. I have to close many windows.
Yeah. So maybe I can start talking just to save
Yes,
time.
please.
And
Yes,
you know,
yeah,
yes.
go on.
And actually, as you'll see when my slides go up, that I actually started with my presentation with a quote that I took from our friends, the UICC, which is on their website, where they said that UAC cannot be achieved if cancer, as the second leading cause of death globally, is not covered by national health benefits packages. And I think the presentation from Dr. Asmas dwelt on that and spoke to that in a good way. Yes, please, could you go to the next slide? Yes. And I think what we have seen is that access to optimal cancer care has invariably led to better cancer outcomes, has supported early detection, treatment, and post-treatment care. And data is showing us that, in fact, the mortality to incidence ratio in low and middle income countries is 20% higher than it is in high income countries. And that is basically because of the improved health financing mechanisms, the social insurance that ensures universal health coverage and health insurance. And therefore, whatever UHC approaches are adopted, they need to assure that there is more affordable cancer care in a way that would benefit all stakeholders. Next, please. So in my presentation, I will speak to the linkages on UHC and cancer in alignment with what Dr. Asmas has shared. I'll delve a bit into the WHO Global Cancer Initiatives, speaking a bit on each of cervical, childhood, and breast cancer. I'll touch on palliative care also, and because it is indeed important for this region, and speak a little to the progress and way forward for the EMR. Next, please. So I'd like to refer to this figure that is also in the special report on cancer that Dr. Asmus referred to, and which shows us the different aspects of care that would be needed across the cancer continuum, across the different levels of care, and speaking from prevention to end-of-life care. And we are a diverse region with a big number of countries that are in emergencies or in post-emergencies. We suffer from many different aspects that I've listed on the left of the slide. There is data that shows the high out-of-pocket spending, as has been shared by Dr. Ibtihal in her introduction. We suffer from human resource shortages, not only in absolute numbers, but also in the specific subspecialties that are needed to manage oncology cases. Issues of diagnostics have also been referred to by Dr. Ibtihal. I do not need to go into them. The issue of oncology medications seem to be better off in the region, but still there were critical gaps, especially in countries that are facing emergencies and sanctions as a result of their political situations. Issues of waiting time, referral systems, and navigation systems all challenge the delivery of cancer care and lead to more abandonment of treatment. So in WHO, what guides our work is the GPW 13, and which is addressed through the triple billion targets. And although it is more of an integrated approach, cancer has thankfully managed to find its place in its different goals. So under the first goal, which looks at universal health coverage, cancer is being addressed in terms of improving access to quality essential health services, including cancer. And this is where we aim to achieve the goal that Dr. Asmus spoke about and work towards the definition of universal health coverage, whereby all people have access to the full range of quality health services when and where they need them without financial hardship. And then also in goal 3, which looks at a healthier population, we're also looking at the various aspects that impact cancer and help us address aspects of cancer prevention by looking at health determinants, addressing the best buys, working on governance mechanisms, and bringing together the partnerships that enable joint effort towards addressing cancers. Next, please. So the WHO has support that goes across the 3 levels. So from the WHO global guidance, as you see on the screen, we have guidance that supports the 3 global initiatives that I referred to earlier: the WHO Global Initiative on Childhood Cancer through the Cure All framework. The WHO Breast Cancer Initiative has an implementation framework. It was launched earlier this year. And the WHO Global Strategy to Accelerate the Elimination of Cervical Cancer as a Public Health Problem, which just in 2 days we will commemorate 3 years since its launch. Also, WHO supports, together with its partners in IAEA and IARC, the work on cancer planning, and that is through implementing impact reviews, which pave the way for these cancer plans in a good way by doing an in-depth analysis of the situation on the ground in our different member states in relation to cancer services and their delivery. And from that global support, we move to the regional adaptations, which Dr. Asmus has spoken about in detail. I will not dwell on them. We have the regional framework that guides our work, and where we have adapted regional strategies in line with the global guidance. Next, please. And then we move on to country level work. Next, please, Ibtihal. National implementation, sorry, the previous slide, please. So national implementation in line with these 3 priority areas of work in cancer. In childhood cancer, we are doing work in different countries. This year, the number of focus countries have expanded in a great way. So instead of having only one Morocco as our focus country, we have added a number of focus countries, as you can see on the screen. We also have piloted in 1 country of the region, 1 of 6 countries globally, that is piloting the global platform to access medicines for childhood cancer, and that is happening in Jordan with support, of course, from St. Jude's. And we also have country activities that have been implemented in Syria, Iraq, Palestine, as well as Yemen. In breast cancer, we are working with countries to support efforts on breast cancer, both at facility level as well as using other innovative platforms such as school health platforms. We are also, since the launch of the GBCI framework, we've been discussing with countries the adoption of the GBCI KPIs in order to support their efforts and monitor their implementation. And just next week, we will be having a technical consultation that looks at women's cancer, both breast and cervical cancer, in order to guide implementation by providing us with data that supports the returns on investment from the returns on investing in breast and cervical cancer. And then for cervical cancer specifically, we have developed and rolled out a regional cervical cancer elimination strategy. There is great effort from the different departments in WHO, especially our colleagues in EPI, in terms of supporting the vaccination efforts in countries of the region and the Gavi application processes, as well as regional partnerships that support awareness raising and advocacy efforts. Next, please. I will just touch on each of the three initiatives just to tell you what WHO is talking about, but of course, to justify why EMR is focusing on them, it would be good to touch on the burden. So for cervical cancer, it is the 6th most common female cancer in the region. It affects women in their most productive years, and therefore not only impacts on the woman, but also on families and societies. The incidence range varies widely from 2.2 to 25.1. So we do have some of the high burden countries in this region, but we also need to acknowledge the fact that this could be an underestimation. Data is not telling us the whole story, as well as the projections tell us that there would be an expected doubling by the year 2040. Next, please. And therefore, in line with this burden and the global strategy that I've mentioned, we have launched a regional cervical cancer elimination strategy on 11th of January this year, and that emphasizes different parameters and different areas, if implemented, would vastly support the efforts in progressing towards universal health coverage. I'd also like to highlight that our regional adaptation added actions that you see at the bottom of the slide, specifically in relation to health system strengthening, which is much needed when you address universal health coverage issues, as well as issues of communication to reduce the stigma and raise awareness and advocate for cervical cancer elimination. Next, please. For the burden of childhood cancers in the region is growing, as it is in other parts of the world. We have an incidence of 33,000 in 2020, and it's actually the third leading cause of death in children between the ages of 5 to 14 years. The slide on the right shows you the 6 index cancers that are being prioritized by the Global Initiative on Childhood Cancer. Next, please. And when it comes to looking at how the GICC addresses UHC efforts, it is part and parcel of the Curol framework. The second of its 4 pillars, the U, addresses universal health coverage by integrating childhood cancer as part of the full range of essential quality assured services and included in benefits packages. And many of the implementing countries for the GICC in this region are also giving great attention to this pillar out of the 4 pillars and the enablers that are provided through the framework. And just to share that the initiative aims to achieve a 60% survival to double the survival to achieve 60% survival for childhood cancer by the year 2030. Next, please. And then last but not least, the burden of breast cancer in the Eastern Mediterranean region. We do know that it is the most common cancer among women and the leading cause of cancer death. We have huge numbers documented as of 2020, according to GlobalCan, almost 120,000 new cases and almost 50,000 deaths. According to our country capacity survey that was done in 2019, 17 of the 22 countries in the region reported having breast cancer screening. If you look at the stratification of our countries, we see that 100% of Group 1 countries have that. 90% of group 2, and 33% of group 3. But we need to acknowledge that this breast cancer screening is in most cases opportunistic, and we do know that opportunistic services in fact widen the equity gap rather than closing it. And then most countries report covering 10 to 50% of their target population, which is a good figure, but of course we can do more. And 16 of our countries report having early detection integrated within their primary healthcare services. Next, please. And this is what the GBCI tells us. It has 3 pillars. And most importantly, I'd like to highlight the KPIs that you see at the bottom of each of these 3 boxes that indicate the pillars. We are encouraging countries to consider these KPIs to inform their current work, to guide it, and to support progress and monitoring of their interventions. And the GBCI aims to reduce breast cancer mortality by 2.5% per year by 2040, preventing 2.5 million deaths. Next, please. And then, of course, we cannot end without mentioning palliative care. I'm glad Asmus mentioned it. I'm also mentioning it. And we do have a lot to share on palliative care just because it is so important for us in this region. So Dr. Asmus has mentioned our special issue. We're working on the development of regional palliative care indicators. And in fact, we've started working with Morocco in order to do that. We're also supporting work that targets the health workforce on palliative care. We have done work specific for countries like Morocco and Iraq, but we're also targeting across the region support by linking through our WHO collaborating centers. We're offering opportunities for fellowships in palliative care. We've done that last year. We'll be doing it again this year. And just to let you know, we have the Palliative Care Expert Network that is very committed to supporting efforts in this region. It represents many countries from within this region, as well as some experts from beyond. And I've just highlighted the different working groups to show you that we have a great focus on service delivery, looking at what are the models of service delivery that work best for our region, looking at the experiences that there are, and also looking at how could we expand this to primary healthcare level. Next, please. So in my last slide, I just need to reiterate what I said at the beginning, that we cannot achieve UHC if we do not include cancer in our benefit packages. And to do that, we need to think of all those aspects that would serve our cancer patients and ensure that they get the care they deserve. So we need to think of access through decentralized care, through satellite centers that improve access in far-off areas, the health insurance coverage, which would ensure that people do not go into catastrophic health expenditure, the capacity building with a special focus on subspecialties that are needed for oncology, task shifting where needed and where feasible, the patient navigation systems and clear referral pathways to ensure that patients do not suffer as they seek care, treatment protocols and adaptations that are country relevant and doable, and the audits to ensure that care providers stick to these protocols and implement them, and then oncology medicines that are in line with WHO recommended lists, just to ensure that the services we offer are realistic and in line with what is affordable. With this, I'd like to thank you for your attention. Apologies if I've taken longer, and looking forward to more fruitful discussions during the rest of the session. Thank you, Dr. Ibtihar.
Thank you very much, Dr. Lamia. This is what we want to hear. I mean, this is all what is, this is a collective work, WHO and civil society, to be able to achieve the universal health coverage, the novel concept for health for all. I want for me, for my grandchildren to have health care whenever no matter where they live, and no matter what the situation. So this is what we are working for. I will see whether we have any question. Otherwise, we will, for the sake of the time, we will move to the second part of the panelist interaction and moderated discussion. So Balqis, can you see if there is any question?
Actually, we do not have any questions so far from attendees.
Great. Great. So, colleagues and the audience, again, I thank you for attendance today and joining us. And we are very privileged to have, we are very privileged to have esteemed expert for cancer and other related area from the region, from different, we could say, socioeconomic level in our region. So let me introduce our panelists, and I would like to welcome them again. And we will introduce them on as we go. So we have Dr. Khalid Al-Saleh. He is from Kuwait. He is the co-chair of the Eastern Mediterranean NCD Alliance, and he is the General Secretary for Gulf Cancer Federation. Ms. Nisreen Katamish, she is the director of King Hussein Cancer Foundation and Cancer Center. And Dr. Pir Enhouri, he is from Lebanon. He is the special advisor for Minister of Health, Lebanon. Dr. Iman Sabati, she is a surgical oncologist, Lebanon, from American University in Beirut. And Professor Ahmed Mohammed Badib, he is a medical oncologist professor and from Yemen and currently in KSA. And Dr. Nahla Jafar, she is a consultant palliative care from Sudan and currently working with WHO. Dr. Noreen Zafar, she is from Pakistan, and she is a lead for Girls and Women Federation. Pakistan, sorry, Dr. Noreen, I would like to introduce you as a founder of the Girl and Women Health Initiative, SRH Champion Royal College London, and country ambassador for IBVS, International Papillomavirus Society. Dr. Laith Mullah Hussein, he is a radiation oncologist consultant from Iraq, currently in Canada. And Dr. Imad Trish, she is head of the Policy and Strategy King Hussein Cancer Center. Welcome all of you for you, and thank you for your time. As we listen that universal health coverage is the promise of the government. So I want to hear from you, starting with you, Professor Ahmed from Yemen. How do you see the concept of this promise, how it is to be converted into reality, taking your perspective from Yemen as a medical oncologist? We want to hear from you, is all people currently affected by cancer are able to get the treatment they need? And what are the challenges, basically?
Thank you very much. Thank you very much, Dr. Ibtihal. Thank you for the Eastern Mediterranean NCD Alliance for this great opportunity. And I send to you the greeting from from the public in Yemen, because they are suffering now from the sequels of the catastrophic sequels of the war. Despite of that, still we have good news from Yemen. Despite of all these challenges, the good news that cancer care and generally the public health service are free for all, not only for the citizens in Yemen, but also for those people who are non-citizen and living in the country. So this is a commitment from the government, and this is, good news, because it will, pave the way for the the UHC to be implemented in the country, because we are feeling that part of the commitment of the government and the political intent that there is intention and plan for improvement. Now, during the war, really we have new cancer units started. This is the good news also. Despite of the conflict, we started in some governorate new cancer units. And not only this, but also during the war, the MOH approved and paid operational cost for the new units. These units were, some units were covered, cancer units and centers, they were covered by the charity and society. Just some societies which help now converted completely to the governmental coverage. This reflection of the governmental commitment toward the better for the public and for the health promotion. But still, despite of that, we have many challenges because of the long war, which almost now since 2011 we started suffering from this long conflict, until now not yet settled 100%, and we hope inshallah that the peace is coming soon. Now, first of all, regarding your question about the challenges faced by the patient, you know that almost most of the people there, they have interrupted salaries, and they don't have almost regular payment from the government, and most of the people there, they are governmental employee. This is the first point. And the impact of the war on the currency and the exchange rate, the currency lost 5-fold of its value. So imagine for the public and the priorities of people when they about the health care, when the currency almost lost more than 5-fold of its value. In addition to that, we have very weak from the start infrastructure now, especially for the hope of the future, which is the health coverage, insurance health coverage. Now, despite that, most of the governmental employee supposed to be covered by governmental insurance, but there is no established system. And the nuclei of the health insurance that started before the war, almost all these companies that started to work in the private sector to establish some insurance service, destroyed by the effect of the war. So what I mean, so this led that most of the patients, they are paying from their pockets, and almost 2015, as per WHO data, we can say that the share of out of pocket in Yemen from it is almost the highest rate among the regional countries in the region. Almost 81% of the people, they share out of pocket for the health care. So this is one point, ineffective insurance, interrupted salaries, the conflict sequels on the health system. And so starting from the screening program was opportunistic in the country before the war. And it is mainly based on the cancer society's effort, which not well established system, which is not the proper thing. And we recommended last in May this year, we conducted a workshop to improve the early detection, and the recommendation that we have to utilize the primary healthcare centers. We have this service wide. We have great programs in the most of the universities for primary health care and for the family medicine. So, but we are underutilizing such service. So we suggested that such centers can be properly utilized to provide the screening and early detection, because all these centers belong to the MOH health system and can provide free service for the people. So it's a challenge start from the early detection because of the war situation, but we can replace this challenge to, success and positive way. Now, the diagnosis of cancer, we are facing challenges that all the surface of sophisticated labs and pathology labs are concentrated in the center, and mainly in the capital Sana'a and Aden. Well, the country we have almost 33 million inhabitants, and most of them distributed, in rural areas. Now, when we do starting with the diagnosis of cancer, we are suffering that the diagnosis, the basic diagnosis can be done, but when it comes to reach to final diagnosis for cancer, we have to send the samples to Sana'a and sometimes to Aden, and this will take long time, and the patient should pay a lot for such investigation. So this is one point of weakness that we need support in it, and we may discuss it to make the facilities available in a non-central way in the cancer centers, which is covering all the governorate. Now, when it comes to the diagnostic modalities, as we know that we don't have the adequate diagnostic and imaging facilities. Now, zero PET-CT scan in Yemen, and we know that many cancers, especially those curable cancers like lymphoma, we are treating them tailor-made based on the PET-CT scan. So at least one machine of PET-CT scan should be available there. So the patient, they travel now outside the country to do PET-CT scan. And the other thing that the success which we have in the nuclear medicine department, which was started in the capital, it closed from day one of the war, because the situation in Yemen and the restriction for the entry of the radionuclear active substance. So we have the labs and the infrastructure for the nuclear medicine, and we started doing the nuclear imaging, but it is now closed because of this precautions for the entry of the radioactive material to the country. So, and we hope that the International Atom Agency to find a way in releasing and opening the way for these materials to enter again back to the country. Now,
thank you, Professor Ahmed. I will come back to you regarding what are some of the suggestion and solution, because it sounds like it's so complex, the situation, in Yemen. Cancer by itself as a package and services is a complex and very expensive, despite, what you have said, thinking, the government have a strong commitment to provide the services for everyone, but still, there is a huge challenges in Yemen, and the war situation and the political instability is also increase that challenge for Yemen. I will come back to you regarding your suggestion and solution, and more about the story of Yemen after the other panelists, because we want to move now to Iraq, another country also suffering from conflict and war situation, and we want to hear from Dr. Laith. Dr. Laith, what do you think as a radiation oncologist, how radiation facility as example, how it is accessible and financially accessible to people who are affected with cancer in Iraq, and what are how do you examine the situation?
Thank you,
Over
Dr.
to you.
Abdihal. Thank you, Dr. Abdihal, and thank you for all the panelists and who shared their opinions and presentations. Obviously, Iraq passed through difficult decades of wars and sanctions and embargo. Many of the Iraqi patients suffering from difficulty in getting the accessible and acceptable level of care in the public health cancer centers, and also in particular for the radiation therapy. The radiation services in the last 10 years has got some improvement. In 2002, when I entered the field of oncology, we used to have 4 linear accelerators in the whole country. And at that time, we used to be around 25 million. After 10 years, in 2012, the number of the machines became 12. The last year, 2022, the number of the radiation machines is about 34. So like imagine from 6 machines in 2012, now it is 34. Still, the goal, if we will calculate 1 machines per million, we need at least now 40 machines in the public sector. And it's better to be 2 machines per million, which means that it is 80 machines in the whole country. Because now we have like more advanced techniques in radiation therapy that needs more time and less number of patients per machine. From the 34 machines now we have in Iraq, we have about 25 machines in the public sector and 9 machines in the private sector. Certain regions in Iraq are like suffering a lot compared to others. For example, Nineveh, Mosul city, Tikrit, Salahuddin, and Anbar, Ramadi, and Diyala, and also Kirkuk. These 5 cities, they don't have any radiation services, and they are like comprising about 25-28% of the Iraqi population, and they have been affected by the ISIS occupation. So the patients from these countries need to travel to either other provinces or sometimes travel abroad to get the required services. So still the waiting time in certain centers exceeds 2 to 3 months and sometimes 6 months for the adjuvant treatments, which is in oncology practice is totally unacceptable. The financial hardship is a lot on the patients from these cities. In other cities, like in Baghdad and the south cities, usually there is a good number of machines and they can accommodate the need of the people living in these cities. The private centers started in Iraq in 2017 and became functional in 2019. So the first radiation service in the private sector started functionality in 2019 in Baghdad, and then there are now about 4 or 5 centers. All these private sectors are for profit. One of them is not for profit. They are helping in the need for the patients, and so for the systemic treatments, there are some also gaps, and we are not yet completely fulfilling the essential medicines for the surgical services in Iraq. Mostly it is in the private sectors, so the patients need to pay from their own pocket. There is no reimbursement policy, although the cancer care services in the public sectors is usually free of charge, and it is not only limited to the Iraqi citizens, but to any cancer patient wants to be treated in the public sectors and register there, they can have the treatment for free. But as I told you, the long queue time sometimes, and there is some issue about maybe the acceptability. They need Some patients need like a special private care, and we are like having a bulk of patients and don't have the capacity for this issue. So still,
so Dr. Laith, I
a
can
need.
see, you know, like a clear similarity between the issue, the challenges mentioned by Dr. Professor Ahmed and you.
Yes.
And sorry for I had to interrupt because of the sake of time.
Yes.
And I want to give time for other panelists to also to reflect on this issue. We, I mean, what you have mentioned, majority of the things has been referred to by our colleague in WHO. So let me move to another challenging area and challenging country is Sudan. And Sudan also one of the challenging area Dr. Nahla is experiencing is palliative care. Dr. Nahla, in just 2-3 minutes, if you can summarize to us the accessibility of palliative, financial accessibility of palliative care in Sudan.
Fortunately, first of all, thank you for the invitation, Dr. Ibtihal. I'm honored to be with all of you. And fortunately, palliative care is not expensive. It's something depending on training, and that is available, and it is possible. Unfortunately, when you don't have recognition of the trained people, you don't have recognition of the specialist, eventually you are losing them. And you cannot sustain services without the qualified and sufficient number of staff. We had a huge loss of personnel. I had a very wonderful and dedicated nurse who just needed a minimal salary from the hospital. She volunteered for 2 years, and she trained very well in palliative care. I even managed to send her abroad. But after 2 years, and they were not offering her a job, she had to go to a Gulf country where she worked in school health. And she tells me, because I met her later,
so Dr. Nahla, do you think the palliative care services was accessible to everyone need the palliative before the war?
Before the war, it's not accessible and not available because the numbers, the size of the palliative care service was not suitable to the needs of the patients. There was like 3 services in the country, and they don't have the capacity for all the patients who need them. In addition, when we speak about palliative care, we have to speak about generalist palliative care, like the basics training in palliative care, where patients' needs like breaking bad news, the communication skills, basic symptom management are met where the patients are. We cannot wait till the patient is at end of life and then he's referred to palliative care. And so there is huge needs in training, huge needs in recognition of the service. And also we had another problem of lack of opioids because there were some shortage for 2 or 3 months every year.
Great, thank you, Dr. Nahla. I will come back to you regarding solution and some suggestion. Let me move to one of the hosting country and also Lebanon. Lebanon is suffering a lot in terms of different crises. So to you, Dr. Bir Ainhouri, what to promote Lebanon to review their cancer strategy, and you are involved in the new cancer strategy, and how do you think this new cancer strategy will address the issue of equity of cancer service to everyone who in need in Lebanon?
Thank you for the invitation. In fact, the 6 traditional pillars of any cancer plan has been directly impacted by the economic, political, and health crisis. Cancer registry is interrupted since 2018. Awareness is not good, and 75% of the citizens are smoking. We have delayed diagnosis, irregular access to treatment, shortage of drugs, and palliative care is simply ignored. Integration of cancer survivors is not well organized. So Considering this situation, the Minister of Public Health launched last July 6th a national cancer plan to restructure the 6 pillars: the data, prevention and screening, diagnosis and treatment, supportive and palliative care, and rehabilitation of survivors and governance. We are now implementing it. We started and things are changing step by step. And we found a solution, at least for access to expensive drugs, with a unique new system in the country.
Thank you very much. So, I mean, the new strategy will definitely deal with accessibility and reduce the financial hardship for people who are needing the care in Lebanon. It consider this issue, right?
For drugs, yes, not for the whole hospitalization for the moment, because insurance collapsed. People are not paying their premiums, even to the national system, so insurance collapsed. So the situation actually is to give availability to drugs and access through a system with a unique ID called MediTrack, and a committee approved the prescriptions. We control that these are real patients and doctors are respecting protocols.
Thank you. I want to move to another important area in cancer treatment is the surgery, cancer surgery. And I'm privileged to work with Dr. Iman from AUB in Lebanon. We've been as a commissioner for the Lancet Commission on Cancer Surgery. The report just released a few weeks ago. And Dr. Iman, she has an extensive experience on cancer surgery in Lebanon as well as in the region. So Dr. Iman, how do you see the cancer surgery situation in our region? And based on your contribution to the Lancet Commission report, can you give us an insight on challenges of cancer surgery in the region, some of it, before we move to the solution?
Sure. Thank you. Thank you, Dr. Ibtihal, for inviting me to participate in today's session. It's really a great pleasure to be here. I already learned a lot from all the panelists. And it was also, again, a pleasure working with you on the Lancet Commission, and hopeful for future collaborations as well. Now, as you know, we work together extensively on the Lancet Commission looking at cancer surgery in the Amro region. And that gave us the opportunity, all of us, to look at all the data available. So I think I have like about 5 minutes to, or a few minutes to summarize. 3 minutes, okay. So for the sake of time,
back to you. Yes,
sure. So I'll try to go over maybe headlines so that we are on track to understand what's happening in the Amro. As a general attitude, it's a heterogeneous area. So you have some that are low middle income countries, other countries are high income countries. So there is disparity in how cancer surgery is distributed in this area. The major highlights is there are issues and like challenges happening in these countries related to cancer surgeons to start with. The majority of the cancer surgeries are performed by general surgeons in this region. And that is because of the lack of surgical cancer surgeons, specialists like surgical oncologists, or perhaps even organ specialists. Like you cannot have a surgical oncologist, you have to have a breast surgical oncologist, a GI surgical oncologist, and so on. And that's not available in the majority of the countries. And if there are, but the number of such specialists is few. So that doesn't help to cover the entirety of the country. Furthermore, the challenges to that is even the political and all this unrest and conflicts in the region. So even those who are already trained and are specialists are actually immigrating and leaving the area to better job opportunities. this another obstacle to having such experts is lack of training systems or fellowship programs in these countries. Only very few programs exist in if any in these countries. Like for example, in Lebanon, we have a lot of specialists that come from abroad, surgical oncologists, like I trained in the US in cancer surgery and others, but we don't have any training program for fellowship cancer surgery in Lebanon. Another issue is with hospitals. So there are no really established or accredited cancer centers, only very few. Like for example, at the American University of Beirut, we have one, but it's not really comprehensive and have everybody together. There is a good example of a good cancer center in Jordan with King Hussein, and I know that we have panelists who will talk about that later, but this is not the norm in the rest of the countries. It's still happening anywhere. And we all know for good outcomes in cancer surgery, you need centralization. Other challenges is there is no audit for the outcomes. So hospitals need to have like mortality morbidity conferences, have to have databases, have to check and these outcomes and benchmark them with international standards. Issues related infrastructure. So in some countries, like for example, Lebanon, Jordan, maybe Saudi Arabia, there are for example, you have laparoscopic devices, you have robotic devices, you have all these fancy technology, but in other countries, you don't have the basic required technology, and perhaps it is available in small amounts. Even an anesthesia machine sometimes is not available in good numbers in one of those countries. Also, I would like to say that even in countries where like in Lebanon or other countries where there are good infrastructure and maybe specialized surgeons, you don't have the real concepts of coordination of care in these cancer patients. So you don't, multidisciplinary teams are not established. They should be a must in every hospital treating cancer, but this is not the reality. There is a lack of those. And I would like to end with one idea also, that access to care is not easy because qualified hospitals, qualified surgeons are usually present in the capital, as has been already mentioned by our colleague from Yemen. He explained that. And you have, even in Lebanon, for example, we have the majority in the capital and maybe the big cities, but then in the periphery, you don't have these. And also it was mentioned also in Iraq, we just heard that the radiation units are in the capital, Baghdad, and maybe other areas, but there are further areas where there's no care, and patients will have to take all the hassle of driving 6 hours or more to get access to a good to good cancer surgery, for example. So I think this is the highlights of all the issues happening in the region.
Thank you, Dr. Iman. We will talk about the solution also, because the report come with a set of recommendations to be implemented in order to achieve the equity. I mean, I know you mentioned King Hussein Cancer Center, and I leave them to the end because they have some good solution, because we've been talking about challenges. So I will leave the panelists from King Hussein to enlighten us with some of the suggestion and solution. And I go back to Dr. Noreen Zafar from Pakistan. And Dr. Noreen, she's been working extensively in the area of screening, cancer screening, and specifically cervical cancer. So Dr. Noreen, what is your perspective on accessibility of cancer prevention and screening in Pakistan and beyond, and how this could be added to the universal healthcare package?
Thank you very much, Dr. Ibtihal. Firstly, it's a real privilege for me to be participating in this event. Thank you for the invitation and all these learned colleagues and yourself. Well, in Pakistan, essentially like the rest of the valued speakers just said, we are dealing with the time of political instability and a lot else is going on in the country. So cancer, unfortunately, is also rising in Pakistan like it is rising globally. And just only in 2020, we had 178,000 new cases, out of which 117,000 died. And this is, I'm talking about general cancer. And the problem with our country really is that the insurance and the universal health packages do not include cancer screening at the moment. Now, since the introduction of the global strategy for cervical cancer elimination and breast cancer initiatives, as alluded by Dr. Lamia, efforts have just been started to incorporate these services, especially breast, oral, and cervical cancer screening, to be integrated into the universal healthcare using the infrastructure that is existing in the country. That is basic health units, primary healthcare, and then tertiary and district health level facilities. So the attempt is being made to train the mid-level health providers as well as doctors to do the breast, cervical, and oral cancer screenings. And then we are in the process of trying to make referrals to the central hospitals for further management. But the real issue remains to be the access of the general public, not the rich people, but the general public. And then also how they're going to get to the hospital. If they do get to the hospital, how they're going to fund themselves, and is the hospital going to be well equipped with staff and resources to deal with them. So steps are being taken to involve the private sector. There are hospitals like Shaukat Khanum Hospital who are now providing free care, and some others like Cancer Care Hospital. And zakat and philanthropy money is now, we hope, to be channeled into the cervical and the general cancer screening. And we are looking forward to an insurance package which would cover the screening as well as the treatment of the cancers for women and men, irrespective of the gender, to ensure equitable access.
Thank you very much. And we will talk about, as I said, some of the solution. Now for King Hussein Cancer Center, Dr. Imad Tarishi is the Chief Strategy Officer. And from a previous discussion with you and Ms. Nasreen, we know that King Hussein is having a challenge also with addressing cancer financial hardship for people who are currently treated at King Hussein Cancer Center. So could you please elaborate more on how a strategy in King Hussein Cancer Center addressing universal equity for cancer care, even for the refugee who are being treated at your center?
So let me start. First, again, thank you for inviting me to this amazing panel. And let me start with this sort of paradoxical statement, which is one of my biggest fears as someone who works in a cancer center and cancer policies, that one day we're going to wake up to find that there's a cure for cancer, but the reality is that we may not be able to afford it. So this is a very important issue for us in cancer in terms of medicinal medicines that are coming for cancer. We have a number of medicines being approved every day, and some of them are really transformational in their effect. But the reality is that most people in low to middle income countries will not be able to afford them. So this is a paradox I want to start with, is that I'm afraid of, one day waking up and finding that there is a cure for cancer, but we won't be able to afford it. That's the pessimistic side. The optimistic side is that over the years, we have worked on really developing equity in cancer care on a number of dimensions. So one of the first dimensions I want to talk about, which is within our formulary, within our treatment guidelines, we have implemented strict cost effectiveness guidelines to measure how do different medicines perform against a certain metric that we have developed, which is a threshold above which we will not be able to include that medicine on our formulary. I remember the chairman of one of the committees said several years ago, said, you know, if we just include every single medicine that gets approved by the FDA, we're going to corrupt the country. We're not going to corrupt just the cancer center. We're going to corrupt the entire country. And so in 2008, that's when we implemented this cost effectiveness threshold. So every single drug that is added to our treatment guidelines is evaluated by the Center for Drug Policy and Evaluation. And an entire health technology assessment is performed. And we really make sure that this drug actually is giving us the results that we want to see. Some drugs give results, but they're just too expensive for that. So looking at value became an important issue. What are we paying for as a cancer center? And this is one way to ensure equity amongst all different types of cancers. So all cancers have the same type of threshold. You know, it's not like because we have a fewer number of prostate cancer patients means we're going to provide them much more expensive medicines. No, it's the same cost effectiveness threshold. So this is one aspect. The second aspect in terms of equity is that although we provide care for approximately 50 to 60% of all Jordanians who have cancer, we still know that there are many patients being treated in some of the Ministry of Health hospitals that are receiving less than desired types of treatments for cancer. And so an initiative that we started approximately a year ago is that today we are operating a cancer unit in Al-Bashir Hospital, which is one of the largest Ministry of Health hospitals. And we expect that we're going to be treating about 1,000 new cancer cases using our own staff, our own guidelines, and hopefully the same results that we have in the main center will be able to produce those same results in Al-Bashir Hospital. So that's another important initiative. And thirdly, we are addressing some of the geographical disparities that some of the colleagues have talked about. And today, we hope that in 12 months, we'll be operating our first outreach center. It's an ambulatory center, but in the city of Aqaba, which is about 3.5 hour drive from Amman. So we have a number of patients who live in southern cities that have to travel 3 to 4 hours to get their treatment or to have even a CT scan. So today, this ambulatory facility will be able to provide chemotherapy, radiology, labs, pharmacy services. And this will be hopefully a start of this regional outreach that we do. So these are the three sort of dimensions of equity that I wanted to discuss now, and we could expand on those later on.
Great. Thank you. Excellent work. Ms. Nasreen, can I bring you also for the same discussion? How do you deal with the financial hardship? I know you have some example from King Hussein to reduce the financial hardship for cancer patients.
Yeah, first of all, I would like to thank you, Dr. Ibtihal, and everyone for this very important session at a very important time where there is a lot of patients who are now suffering because they are denied their right to access for quality cancer care and even basic cancer care because of the current conflict in our region. So it's very important now to show some examples on how we have to work together and translate all these discussions and all what we are doing into real actions in order to save lives and give patients, cancer patients in specific, some sort of hope while we are maintaining the work that we are doing for our patients in our nations. So at the King Hussein Cancer Center and Foundation, we are committed to provide equal access for cancer patients, not only from Jordan, but also from across the region. And as you know, we are receiving a lot of patients who are coming to us, being refugees, being displaced people from different countries, being people who are forced to look for alternatives for their treatment outside their countries because of their the full dismiss of their health systems within their countries. So to do so and to be able to have an innovative, sustainable financing model for cancer patients, we work on two different tracks. One track is for our national people in Jordan, which is through establishing an innovative, sustainable cancer insurance program. We established this program 20 years ago, and it's offered for every Jordanian and everyone in Jordan through corporates and individually. It's an actuarial-based cancer care insurance, and it's provided for people with affordable premiums for 50% of the people in Jordan. And now we are working with the government and with different entities to expand this program at the national level and have it as a national cancer insurance program, as a national fund for cancer care financing. Especially that the government, as you know, is faced with economic hardship and a lot of competing priorities on their budget. We know, and everyone knows, that the current financing model for cancer care in Jordan is not sustainable. And we are, as service provider, facing a huge challenge now with the government to cover the cost of the patients who are being referred to us. So now we are advocating for this program to be a national program under the umbrella of the Social Security Corporation. And we believe that this program could be like the cornerstone or the pilot phase of a national health insurance program that covers everyone. And we believe that if the country adopt this policy at the moment, they will show a huge progress toward their commitment to the universal health coverage. So we are working with everyone, with the Ministry of Health, with the Ministry of Finance, with everyone to expand this program. And we are also doing the advocacy efforts in order to get the buy-in from the public and employers and the private sector, insurance companies and everyone toward having a sustainable solution for and bridging the gap for cancer care financing for everyone in Jordan. This is from one side. The other side that we are working on when it comes to financing cancer care is financing cancer care for displaced people and refugees. And we do that through the Goodwill Funds. We do a lot of fundraising efforts and campaigns and interventions to secure funds to make sure that there is available funding in place to ensure access for quality care for refugees and displaced people. Through these Goodwill Funds, we covered thousands of patients for the past 20 years again, and mainly from Iraqi refugees, Syrians, Palestinians, people from Gaza, in specific, and even Yemenis, Libya, and Sudan, and everywhere. And we believe that without these funds, these thousands of patients could denied access to treatment. And really, we consider these funds as life savings funds. And we are committed to do so. Currently, we are working on launching a huge campaign to make sure also that we are supporting the patients from Gaza. As you know, now we have 8,000 cancer patients who are completely denied treatment at the moment from Gaza. And we should expect, all the countries around Gaza now should expect a huge influx of cancer patients coming to our facilities, and we have to be ready in terms of the capacity and in terms of financing their cancer care. So these are the two models that we are adopting at the moment in order to bridge the gap in financing cancer care.
Thank you very much for mentioning that. Indeed, the cancer financing is a challenge for every country. It's not only for limited resources country, even for high resources country. So with that, I would like to give a chance for the panelists to say some of the suggested solution. And please, because considering the time limit, we want to speak only 1 minute if possible. And we, in area of when we talk about universal healthcare benefit package, we mean how a country can prioritize the cancer services and add it to their, considering their financial limitation, added to their benefit package. So I would like to go back to you again, Professor Ahmed, to say if you meet the government, what is exactly want to advise the government on? What are the key area you want the government to consider for reducing the disparity of cancer care? 1 minute, Dr.
Yeah, thank you. I think the most important is to develop a strategic plan and development of unified national cancer strategy that takes into account the country current condition and economic challenges. Now, what we have all outdated strategy established before the war. So this is the first step. And also, we have to raise the awareness among the MOH leads on the importance of screening, early detection, and treatment of cancer in early stage by using figures. Stories of success. This is the most, so raising awareness, this will convince the policymakers to take the initiative of implementation and integration of this package and the cancer package among this, package. Now, establishing list based on the strategic plan, which we have to start with. The updated strategic plan, which include formulation of this plan all the stakeholders, not one side, because the plan which we have, it was done by the public health team, ignoring the other healthcare workers, especially the oncologist. So we have to include all the stakeholders. Based on that, then we'll establish our unified list of essential cancer medication that the MOH should be committed to provide. Otherwise, now when we conducted the cancer conference last May, the patient died because no tamoxifen, and some doctors and some policymakers fighting for the expensive palliative medication, which does make sense to prioritize. And
exactly,
also,
I think this point have been mentioned by our colleague from Jordan. That
Europe
establishing on evidence.
Yes. Yeah, and also we have to concentrate upon those strategies that will minimize the load of the cancers on the cancers, like palliative care service and home care. Now, most of the cancer patient in my country, they are stage 4. A dying patient at the stage of end of life, and they die while chemotherapy running on them. This is a nonsense. Still, we are, despite of all these, financial constraints, we are spending millions and for dying patient, and just we are increasing their suffer. The concept of palliative care in my country is zero till now. So this is a priority, and as soon we have to start palliative care. We have only one unit, small unit in Aden. Otherwise, we don't have the concept at all of palliative care. Even among our oncologists, the culture of palliation is not there, and also our patients still dying in pain. The narcotics are not there. Last month, one colleague, her father died of cancer. She called me crying. There is no morphine, no fentanyl. She's seeking for opioids. They are not in the country. So ABC of life, dignity and the life, support is not there. So, and we are fighting for expensive medication for millions. And also we don't have, so based on the strategy, we have to put our local cost-effective guidelines, essential drugs, and from there, I think we have to move. This is the way.
Exactly. Yeah. You know, you start with the big things, the strategy and the guideline, and you know, the essential list. Thank you, Professor Ahmed. Dr. Laith, can you say a few words about what you advise Ministry of Health to go for?
Yes, thank you, Dr. Ibtihal. I think there are certain points we need to address. First of all, passing legislation or acts that can address the national cancer control procedures. And number two is to put the cancer services and research on the top list of the priorities of the government, Ministry of Health, Ministry of Higher Education. Number three is emphasizing the establishment of a comprehensive tertiary cancer center or centers in the country. Number four is the empowering the not-for-profit facilities for cancer care and research. And I think if we also add a national cancer control plan or program every 5 years, and to address the challenges and services every 5 years, this also will address or try to fill the gap that we have on every country, I think. And thank you for having me.
Great. Thank you very much for your insight. Dr. Nahla, just your advice for the government to provide. Yeah.
I just want to add one point that hasn't been mentioned, that unfortunately, most of the patients in our areas present in advanced cases, not only because they are afraid of the disease and they have a lot of misconceptions about it, but also because we have little training of the health providers, like general doctors, working in primary health centers, working in the general hospitals. Not all of them have been trained in oncology. And so a rotation in oncology is essential now that we have seen the rising incidences of cancer, and also training in palliative care, undergraduate training. And that this way we can cover a lot of, the needs. One other point I want to mention that in my country and in other countries, people don't care about their health, and then at one point they have cancer, they have a problem, they want to travel abroad, they want to sell the house, huge expenses are lost.
This is what we are talking about, financial hardship. So there must be some source of funding these people. It's not fair for, you move people into poverty. Yes.
But also they don't have the direction. Sometimes it is useless to travel, but they don't see anything. They don't see a quality service. They don't see care for the patients. They insist on traveling because they don't know that this is futile treatment. They travel, they lose this money, and 1/4 of that money would have provided good service for a lot of people in the country. Thank you.
Great, thank you. Dr. Iman, some viewpoint regarding surgical oncology?
You're on mute, Doctor.
Muted, yes.
Okay, so I'm not going to reiterate any of the already mentioned points, all valuable points. I'll try to just focus on items related to Surg Onc. So I think one thing important is for countries really to invest in well-trained surgical oncologists and retain them in the country, because that will help do the surgeries in a more efficient way and less cost, and definitely less cost related to the protracted surgical post-operative morbidities and so on. So, invest in training some of those people and retain them in your countries. To have governmental hospitals which are well equipped at the level of the infrastructure and instruments, and supply a affordable healthcare that the community trusts. Because in Lebanon, for example, patients don't trust doing big surgeries in governmental hospitals, and that's why they seek private sector. And the third and last point is using technology and costly and expensive items should be used when needed in a cost-effective manner. And that comes really from putting some guidelines that are adapted to our communities on, you know, cancer and surgical and so on. And the last point, sorry, this will be the last, is multidisciplinary care, because many times people reach to surgery when it is too late or more advanced, and we could have done much less if they came to us earlier, or if surgery was put as a part of integrated management plan. Thank you.
Thank you. Thank you. Dr. Anhouri?
Yeah, I mean, I want to reinforce what Dr. Iman said. The paradox in Lebanon is that you have a CT scan at every corner of the street in Beirut. You have 24 pediatric oncologists for 350 cases. You have 240 urologists for 1,000 new prostate cancer every year. So the human resources can be trained more and better, but we have a lot, but no more money to access the system. So with the Minister of Public Health, we are thinking about really creating a new approach for health insurance. The system is dead in the country. So we are recreating a new system with private and public insurance to partner together. And this is the work which is undergoing now.
Great. Dr. Noreen?
Yes, thank you, Dr. Ibtihal. Yes, I think for us, the way forward really is to integrate the health promotion and prevention services as a part of the universal health package. We also need to encourage the doctors to develop an interest in oncology and incentivize them appropriately. And I think to ensure the continuum of care, we have to enhance inclusion by integrating the services, not duplicating them, using the existing infrastructure and using staff, task sharing and task shifting where it is appropriate. On another level, we need to sensitize the finance gurus, the policymakers, the planning people, legislative and parliamentary bodies, so that we can have some laws and rules regarding availability of essential services. And likewise, we also require to have the national cancer control guidelines to be in place. And I think it would be helpful to incentivize the private sector, like for providing tax relief or whatever the government can do, so that they can provide subsidized screening and treatment, so that we can actually pick up cancer at an early stage and not get into the stage 3 and 4 like most of our people present. Thank you.
Unfortunately, yes. Thank you, Dr. Noreen. I assume Dr. Nasreen and Dr. Imad, they already provide us with and enlighten us with a good suggestion. So if Dr. Asmas or Lamia, you want to say something as a way forward?
Thank you so much, Ibtihal, and thank you, colleagues. And you're really the experts of, providing those services. And I have really enjoyed to listen to all of you and to hear, your experience, but also your recommendations. And when I try to take stock of those recommendations, and also especially the last round, and look at our framework of action for cancer prevention control in our region, then you're really filling the whole matrix, so to speak. You've talked about the importance of multisectoral action and governance, the financing, the human resources, of course. You also kindly mentioned the importance, and that's perhaps my only point I would like to add, the paramount importance from the public health perspective, of course, of WHO, to really tackle the important modifiable risk factors, especially tobacco and the new products coming out that are really poisoning our populations, and especially young people, and go often unchecked in many settings. You mentioned the importance of early detection. You've mentioned all the components of management in your expertise area, the importance of palliative care and surveillance and research. So I believe we had a very rich session, and we know what to do. We know also what the challenges are, but I think we're building, and sometimes in some countries, rebuilding communities of practice. And I hope that this meeting today was an important step forward for all of us. Thank you.
Exactly. Thank you, Dr. Asmus. We will continue the discussion because I mean, as colleague had mentioned, the way is still ahead for achieving this goal. Lamia, would you, before we hand to Dr. Khalid Saleh for his closing remark, Lamia, do you have any word in 1 minute?
Yeah, just in less than a minute, I just want to emphasize again the issue of patient voices. I think that's a critical piece. Even if we're talking about universal health coverage, we need their voice to tell us what works. We've been talking about innovative and creative solutions. They might give us the answers that would pave the way for that. So just wanting to emphasize that's a piece that WHO is working on. It's part of our work and plans for 2024, and we hope to do a lot in the region in terms of engaging with patient organizations and people with lived experience.
Great, excellent to flag out the patient voice. I would welcome Dr. Khalid Saleh for the closing remark. Dr. Khalid, over to you.
Thank you very much, Dr. Ibtihal. It is a very privilege for me to closing remarking this bridge of the gap for enhanced cancer care in MR. I'm very delighted to be with a colleague and friend. Some of them, I didn't see them since a long time. Today, we are going to enhance cancer care for universal health coverage in the Eastern Mediterranean region. And for this key insight and commitment, we have gained a valuable insight into the challenges faced by the region in providing equitability cancer care, including cancer care during war and conflict. And it is very sad that we are seeing that we are trying since 1 month now to send and medicine for the cancer patients in Gaza, and there is no accessible. Also, there is a recognition of the urgent need to integrate cancer services into universal health coverage to ensure accessibility without financial hardship. Commitment to addressing the barrier preventing marginating communities from access quality cancer care. Also, acknowledgement of vital role cooperation play in the transforming cancer care delivery. So for path forward cooperation and action, we have to emphasize the importance of continued cooperation among experts, policymakers, and stakeholders, encouraging the implementation of effective strategy and best practice with sustainable capacity building. The trade to significant formulating practical recommendation to drive positive transformation in the cancer care with attention to priority in the cancer care. Call of the collective action toward the goal of inclusion, accessible and high quality cancer care and management. And I feel sometimes very sad to hear that some cancer patients till now, they don't have enough opioid to relieve the pain. And this is actually putting over all of us a burden that we have to move together to at least help others for this issue. For closing thought, in closing, let us carry forward the spirit of cooperation and commitment during the session. By working together, we can bridge the gap in the cancer care and contribute to realization of universal health coverage in the Eastern Mediterranean region. Our collective effort today will shape a healthier and more equitable future for all. This is my suggestion and what I understanding from all the discussion. And I hope that we are continuous meet together, giving suggestion, trying our best, particularly in the field of screening, early detection, and offer the management for the patient. Don't forget the importance of palliative care and doing our best for giving the patient what they need, particularly at the end of their life. Thank you very much, and I hope that we are meet together again with some solution and with implementation strategy as some of our colleagues suggest. Thank you.
Thank you very much, Dr. Khalid. On behalf of the Eastern Mediterranean NCD Alliance, I would like to thank you again for your time, for your contribution, and we will continue the journey fighting to achieve health for all. Thank you and good night. Thank you, everyone.
Thank you. Good night for all. Thank you very much. Good night. Good night.